We conclude our second part of our catwalk of innovation. Technology is usually not developed lightly. We reach out to technology if we want to make our lives easier or if we want to tackle complex pathologies. When developing new technologies, and you know, we are in need of different parties. We are to involve different parties and especially different points of views to the table. We have the one of the medical professional, the doctor, who's going to use the technology or prescribe it. We have the one of the developer, of course, who has to know what is there to be developed. And then last, but certainly not least, the one of the patient for whom the technology ultimately is being developed. But, and we heard Hilde Krevits say that at the beginning of this conference as well, do we actually always take that patient into account enough? Are we putting the patient truly at the center of the innovations that we are developing at any time throughout the process? Or could it go wrong there sometimes? In our next debate, we are going to dive into specifically that topic. And I have the pleasure of inviting Jan Vermeir, Alexandra Bogers, and Professor Bart Nutin to the stage for another debate, co-curated and brought to life in collaboration with Health House Leuven.
Today, we are here to discover everything about deep brain stimulation, or DBS. You probably have many questions about this treatment. Maybe you're wondering if the surgery is dangerous. What medical conditions can be treated by DBS? Where are the electrodes implanted? What results can I expect? Can I still travel with the implanted DBS system? Will DBS stop the progression of the disease? Will DBS affect my relationship? Let's go on this journey together. Welcome to Health House. Every 2 months, patients who are eligible for deep brain stimulation and their caretakers from various DBS centers across Belgium are invited to Health House, embarking on a unique educational journey into the world of DBS. These sessions focus on demystifying DBS, offering a comprehensive look at how it works, its benefits, the risks involved, and what patients and caregivers can expect. Specialists provide valuable insights into the treatment, followed by an interactive Q&A session, allowing participants to address their concerns. Via patient testimonials, individuals share their personal experiences with DBS, offering real-life perspectives that went beyond clinical descriptions, highlighting both challenges and benefits. DBS Select was created by researchers, medical professionals, and Health House, together with patients, for patients.
Right, welcome to the stage, Professor Bart Nutin, Jan Vermeir, and Alexandra Bogers. I'm going to introduce you to our audience, and then we're going to go into a debate where Parkinson's disease specifically plays a central role, but then also the role of technology in that, of course. First, we have Jan Vermeir, and when Jan and I spoke in preparation of this debate, he mentioned, well, at first, I'm actually human. I am a human since 1973. And in 2009, he was diagnosed with Parkinson's disease. But before that, he was active at Belgium's Foreign Affairs. Today, he is the president at the Young Parkinson's League and an advocate for breaking the stigma on Parkinson's. Back in 2015, Jan received a deep brain stimulator that was implanted. Voila, and Jan is here to tell us a bit more about his patient journey. He is in good company, actually, because he's here with Alexandra Bogers and Professor Bart Nutin, who are no strangers to him. You two have been part, actually, of Jan's patient journey. Alexandra, you specifically as a deep brain stimulation fellow at the University of Toronto, and you collaborate closely with big players in the industry, specifically on deep brain stimulation. So thank you for representing that lens in this debate. And then we have Professor Bart Nutin, neurosurgeon at the University Hospital here in Leuven, mainly involved in deep brain stimulation and actually a world-renowned expert in that field as well, and someone who planted Jan's device. Oh, no? Okay, then not, but okay, world-renowned. Anyway, thank you. So, quite exceptional, actually, to have these three perspectives at the table here. And that's thanks to Health House, an organization who really aims at bringing together multiple stakeholders to the table, and that's exactly what we have here. All right, welcome, everyone. Jan, I would like to start with you, if I may, and I'm curious to know a bit more about your journey, your story, and could you help us shed light on that?
I hope so. I have a dream that innovation puts people first. Let me tell you my story. Since 15 years, I have to be a patient. A funny thought, actually. Are those words linked? Patience must be patient. Well, they are both derived from the Latin patientia. In 2009, at the age of 35, I was diagnosed with Parkinson's disease. But hey, they told me just have some patience. In 10 years' time, they would find a solution. In 2015, I got my deep brain stimulator implanted in Ghent. But it turned out to work suboptimal. And again, I had to have patience, but I started hoping again. Now, today, in 2024, I'm still a patient who has to be patient, because an update of the current system is not possible. And I'm not okay with that. Actually, I'm done with patience. Wouldn't you? I feel sad and angry that medical science can't help me further, and I'm only 50. I urge you to ask yourself, would you feel the same? Would you be patient, or would you feel sad and angry? And I know there are a lot of people with good intentions in this room. And the people around this table, I thought that would be a table, are devoted to help. So it's nothing personal. And I know you can't hurry innovation. But why can't innovation help? And what can you do? Let me start by the letter. What can you do? Give more realistic information. I'm speaking for 200 young people in my patients group, with whom DBS is more and more implanted, some with positive results, but also some with quite negative results. Innovation is not always a success. Did they get the right information about what to expect? Wouldn't it be better if every person would get the best type of DBS, regardless the brand of the hospital is working with? My second question, why can't innovation help? Well, does innovation put the people first? And I'm sorry to say, my answer would be no. To explain, when you don't provide an update of the old system, when you're only creating new ones to sell, when you are selecting only the commercially most interesting group, where you don't or can't do anything for Parkinson's phase 4 people, when you are treating people as a number, you're putting profit first. But you can also choose to put patients, or rather people, first. And I have a dream to put people in the center of innovation. Why people? When you're from IMEC a couple of minutes ago asked you to raise your hand, he forgot one focus group, that is patients. But it's quite rightfully so that he forgot it, because everybody would have risen his hand. Because I guess everybody in this room is a patient, except for the 2 or 3 athletes who are super healthy. Isn't it true? And don't forget, whether you are doing research, whether you are a CEO or hospital staff, it's about people. People can also be your grandparents, your aunt, your uncle, your brother, your sister, your daughter, your son. People can even be yourself. Let me clarify. In this room of 600 people, 40 of you will be confronted with Parkinson's in their extended family. 3 or 4 of you will get Parkinson's themselves. But hey, just be patient. Innovation will help you. I call the people in this debate, or I call everybody in this debate, to try to speak about people and not about patients. So to replace the word patient by people or person. Thank you.
Right. Thank you, Jan. We've been hearing a few aspects where we can actually talk about. I've heard, we have to put people first. That's the core message. But then there is updates of systems that don't happen anymore. There is commercially not interesting things anymore. So, Alexandra, from your perspective, from the industry, could you react to Jan's story?
Thank you. Thank you very much. So thank you, first of all, for the invitation. Thank you very much, Jan, for the excellent testimonial. So this is what the batteries look like nowadays. You more than anyone knows this. So a deep brain stimulation battery, and then there you go, the electrode. And I think that ever since 2015, there is a lot of innovation been going on. And I think that the industry listened to people like you who have non-upgradable systems, because nowadays these batteries can be upgraded through the skin, so without actually replacement of hardware. The software updates can happen nowadays. So that's, I think, an amazing jump forward as the industry has done so far. And then to bridge one of the other points you made in your testimonial is patient expectations. So I'm not just wearing the industry hat today about innovation, but also in terms of patient education. What our collaboration with Health House is all about is education patients about what to expect from surgery. And I think there is a point that you very validly made, that there is a lot of opportunity still lying there, what we try to fill with Health House, but there is still a lot to be done on that behalf. Thank you.
So I hear the industry has been listening somewhat already, with rechargeable batteries as an example there. And then, patient expectations, that gap is tried to be filled by education. Professor, what is your take on Jan's story?
Well, I am amazed with your testimony. I have met Jan several times recently, not at the time of your surgery, but I think you said it very, very clearly as a patient and as a person.
You can speak.
Do you hear me?
Yeah, this is better, thank you.
Okay. So I think I have the privilege to be a doctor, and then I'm close to the patient or the person. So, to me, for a doctor, let me say, the patient is central, and I can see problems. The problem is if the patient is not enough treated, I can think of an idea and then try to develop it as a clinician, as a researcher. Mm-hmm. And if I want to develop that, then I probably need the industry to go forward. Mm-hmm. And of course, it's not only about improving a certain therapy, but I may, as a doctor, also see other patients that have a disease where no deep brain stimulation is done yet, but where I can see a possible advantage of deep brain stimulation. And to develop that, I definitely need to go together with industry and with other scientists, basic scientists, industry. We need to get money, of course. Yeah. But that would be a bit my response on how to innovate and still look at the final goal is to improve that patient that did not have DBS yet and to improve Jan. Yeah,
indeed. But in Jan's story, we heard that certain updates are not being done anymore. What is to be done there? Is Jan's case lost then, Alexandra?
I don't think at all. So industry is making huge leaps forward to continue their research and more into a patient-centered way, actually, because another thing we may want to bring up is that legislation does not allow an industry partner to directly communicate with a patient, unfortunately.
Right.
Where, however, lies the possibility is our patient associations, one of which Jan is very doing an amazing job as one of the chairs, the presidents of the Young PDA Association. So I think that industry really tries to reach our patients through those platforms to try and listen to their needs and then try and solve their specific needs.
Mm-hmm. Okay, so those patients and people's organizations like Jan is the head of is important. How does that happen, Jan? How do you bridge the gap between the industry and the patient? Can you explain a bit?
It's a complicated story, but we try to give information and we try to improve when patients are talking about how surgery has been or how DBS or something or medication is helping them, or especially when they are not satisfied, we tried to mediate the situation by giving information. Mm-hmm. And also people that are expecting a DBS, for instance, we try to give them enough information so they know that the result is not always positive.
Right.
So again, and to go back to your question, is Jan's case lost? Well, I do remember, Alexandra, you saying that the current innovations cannot be implanted in my brain anymore. Well, or technically, that my system cannot be updated. So it's not positive for everybody yet. So I'm happy for the future generation of patients who will get, of people who will get this system, but it's not anymore for people who have had it. So that's one of my questions. Actually, it will be one of my final thoughts as well. So if the industry is developing something, please think not only about how the patient is doing better a week or a year after your innovation has been put into practice, but how will this how will this person be 10 years after it? Will he or she still be okay? No. And will he or she still be helped by the innovation, or will a different system be necessary? And why can't you think ahead? Why can't you think before implanting a new system that it will need an update 20 years after or 10 years after? Because innovation seems to be short-term thinking.
So we need long-term thinking. Bart, what in your opinion is needed to install that? Are we there yet, that long-term thinking for people, patients, to develop technology that is not only helping today, but like on a longer term?
Maybe I may change the topic from Parkinson's disease to another disease where we did deep brain stimulation. I was part of the team that developed deep brain stimulation for obsessive compulsive disorder.
Okay.
And how did it start? There were patients, and there was a committee of neurosurgery for psychiatric disorders, so we really understood the problem very well. And then I talked with the industry, Medtronic, not to name a name. And so personally, I thought that deep brain stimulation might be of help there. Medtronic also saw the possibility, and together we looked at patients. So it is not only collaboration between the industry and the doctor, but also look at a patient, talk with patients, see what is the problem and how can we solve that in the long run.
And really involve those patients.
Really involve them from the beginning.
Yeah.
But we, of course, actually we first did experiments in rats and then went to the human, and then there was CE mark, and now there's reimbursement in Belgium. And now there is no CE mark anymore, but that's another problem.
Unfortunately, let's park that topic for now. Alexandra, just as a final conclusion, from your perspective, what is the next step in this to get that patient, that people actually, that person, more centrally into the debate?
I think it's a word that we've heard already this afternoon, collaboration. Absolutely collaboration. And as said, the industry may not directly communicate to a patient, but can via the patient organizations. But for instance, I work at the university hospital, and there we obviously can communicate directly to our patients. And in Toronto, we have this amazing organization, or the amazing board, which is called our Patient Advisory Board, which is actually a board of patients advising us, researchers, what to do. And so at the University of Toronto, we really try to fill the need that our patients tell us where exactly that is.
Okay, so really listening to patients, patients advisory boards, that's a good hope for the future, actually. There is a need for information for patients, but also for the industry. There is a need for more collaboration, for closing that gap. Thank you so much for having been with us, Alexandra, Jan and Bart.
Thank you, Marjolein.
We have been talking patient centricity, or should I say people centricity, in this debate, and the challenges that come with that. And what better way to make that people centricity even more tangible with another real-life example catalyzed in Leuven. We are honored to invite Julie Verlinde and John Murphy to the stage. Julie